सरकारले COVID-19 रोग खाली जो कोहीलाई पनि लाग्न सक्छ। यसबाट बच्न समय-समयमा साबुन पानीले
All right, so we can start. So once again, colleagues, thank you for joining this webinar on the HRP revision. Today I'm with myself, Antana Dobamo. I'm leading the GNC country operation support, and with me I have David, who is leading the coordination help desk, and Victoria, who is also leading the Nutrition Information System Help Desk. So over the coming 1 hour or so, we will be focusing on the global HRP revision and also the country level, the global HRP monthly update and the country HRP reviews. We understand that some of the countries have already started the country level HRP review exercise, and the global HRP was launched back in March, and it's supposed to be updated on a monthly basis. Now the April update is due to be published by early May. So, but also we understand that the number of countries included in the GHRP and those countries which are doing their country level HRP revisions are keeping on increasing. Now it reached more than 60, and it is anticipated that the number will increase over the coming months. So it is with this in mind that we thought it will be helpful to have this webinar because there was a global guidance which was released by OCHA by around mid-April, and that general guidance on the revision of the country HRP and also the monthly update of the global HRP, we found it to be more general. So we thought that it would be more helpful to discuss with you guys and to add more clarity to the global guidance. So in today's discussion, we will first look at the overview of the global humanitarian response plan, what it is about and what does it cover, what is its focus, and how it will continue to be updated over the coming months. And then we'll look at also, when it comes to the country revision of HRPs, what are the important considerations, both nutrition-specific considerations which you need to keep in mind, and also general considerations which are important to know. And we hope this today's discussion, and also subsequent maybe one-on-one contact with the help desks and myself, it will help you to better prepare for the upcoming monthly update of the global HRP. The countries are expected to provide a monthly input to that. And then also countries with existing HRP, humanitarian response plan, they are expected to revive their HRPs. And also countries which are not already included in humanitarian response plans, they may also be required to release flash appeals. That depends on the country context. Those countries also might need some guidance on how the need analysis and response planning in COVID context should be done. So in general, this is just to give a clarity and also to help you prepare for upcoming revisions of HRPs, and also a monthly update of JHRP. If there is also a flash appeal to be released in your countries, we hope that this webinar will help you. So having said this, I think we could go to the slides. First, I will take you through the the, the general overview of the global HRP, and then also some important considerations while revising the country level HRPs. So, Victoria, would you share your screen, please? Victoria, you hear me?
Can you not see my screen already?
I am not seeing. Okay, I see. Is everyone is able to see it?
Yes.
Yes, fine.
Okay, so as I said, the global, I think it's very important to really distinguish between the global HRP, the global COVID HRP, and the country level HRP revisions. The global HRP, as most of you might know, it was launched back in March and is expected to be updated on a monthly basis. Already, the April update is almost near completion, and it will be published officially early in May. And so the global HRP, it covers the immediate humanitarian of COVID-19. It doesn't cover the indirect social microeconomic consequences of COVID. It simply focuses on COVID needs. Initially, when it was released, the total requirement for the global COVID HRP was 2 billion. We'll see whether that requirement may or may not increase in the April revision, because the country financial requirements are going to be included, and we'll see whether the requirement will increase or remain the same. And the JHRP, one important aspect is it is based on country level adjustments to the needs and response. So as I said, in the initial stage, I think close to 40 countries were included in the JHRP, but subsequently that number has increased, and what the latest figure I have a couple of weeks ago was the number of countries included in the GHRP will be more than 60. So based on emerging needs, COVID-induced needs, the countries included in the HRP will be increasing as we continue throughout the year. And then also, it is very important to underscore the fact is that the GHRP focuses on the most vulnerable population. It doesn't necessarily focus on the way countries are focusing on COVID response. It doesn't necessarily look the entire population in context, in a particular context. It rather focuses on the most vulnerable population who are normally considered as a humanitarian caseload or people in need of humanitarian response. Colleagues, would you mute your speakers, please? Okay. So, and also the GHRP not only covers HRPs, but also there is an element of readiness and preparedness plans, which in some countries, they may not necessarily have HRP, but they may have some readiness and preparedness plans. So that's also included in the HRP. Some countries who already have HRP in place, but when the JHRP was released, the HRP wasn't revised. Instead, they have a country level readiness, COVID readiness and preparedness plan. So that plan partly is included in the JHRP. And then also it's important that operational context is also an important element that's included in the JHRP. So just for you to understand that the JHRP is more general, focusing on COVID needs, excluding impact of indirect social macroeconomic consequence of COVID. It is also considered as an aggregate of the country level adjustments on the need analysis and response, focuses on the vulnerable people, and element of readiness and preparedness is included. And it has three important priorities, I think, are very important to know because it has implication on how we prioritize activities and adjust our HRP in the country context. The three priorities are simply, one is more health specific, focusing on the containing the spread of COVID, decreasing morbidity, mortality related to COVID. The second one, which is very important and relevant to nutrition, is focuses on decreasing the deterioration of humanitarian assets, rights, social cohesion, and livelihoods. What this means is, under this priority, there are three important components which are very important for us to know. One is the priority, the focus of the HRP, whether it's GHRP or country level, should ensure that the ability of vulnerable people to have their additional needs met should be preserved. What it means is that people who are already vulnerable may need additional assistance as a result of COVID. Then the HRP in the country level as well as the GHRP should focus on covering those needs which are increased as a result of the impact of COVID. Another important element is the prevention of infection and continuity of services, which are services that include health, immunization, nutrition treatment services, provision of food distribution, water and sanitation. Any service that's provided under the humanitarian assistance should be delivered in a manner that doesn't allow the spread of COVID, and that ensures continuity of services to the population. So this is another important element I included under priority 2. Again, the third element under this priority 2 is supply chain. Because of the impact of COVID, movement restrictions, international travels, movement of goods has been impacted significantly. That definitely will have an impact on also the delivery of and availability of important humanitarian supplies. For example, when it comes to nutrition specific communities like RUTF, RUSF, or other important communities that are required for delivery of nutrition emergency services. So the three elements are covered under the second priority. And the last one is more of an advocacy in focus, particularly focusing on ensuring that the vulnerable people like IDPs, migrants, refugees, who may not necessarily be included in some cases in the country COVID preparedness and response plan, should be included in the HRP. So these are the usual targets for the humanitarian assistance. But in case of COVID, it is the focus of the GHRP to ensure that the humanitarian actors, both at the country level and globally, need to advocate for the most vulnerable groups such as the IDPs, migrants, and the refugees. Next. Right. So that's more the global HRP. As I said, it covers, it includes country pays, and it gives the general global overview of the needs and the financial requirement, and also it has a component on the key indicators to be tracked during the course of the year. Now, when it comes to the country HRP revision, I think it's very important, as I said, to differentiate the two. The two are complementary, but they are not the same. The country HRP revision is done based on the country level decision by HCT or UNHCT or whoever is coordinating the humanitarian actors within the country. So revision is in-country decision, but in most cases, especially in the countries where we already have humanitarian emergencies, it is more likely that revisions happen. And we have seen also a number of countries have already started the revision exercise. But I think here, what we would like really to clarify to you is, because this revision is a bit different from the usual revisions we do, because the usual revisions mainly depend on the need analysis frameworks which we normally work on during the third or the fourth quarter of every year as a part of the HPC process. And then during the course of the year, we look at those the indicators and then see whether there is a significant change that increases the different sectoral needs. And then based on that, we come up with a new need. And then also the targets also will be determined depending on the expected level of funding or the ability, the capacity to implement those activities. In this case, the main driving factor, unlike the usual HRPs, is COVID, the pandemic. It is not the conflict, it is not the drought, it is not the other common stuff. So the main difference is the main driver of this revision is the pandemic and its impact. So in any case, the main objective of the country level revision is to make sure that the impact of the COVID pandemic, in addition to existing needs, are addressed on the ongoing humanitarian response. So in another word, it means is that existing humanitarian needs should be covered, the existing humanitarian response should continue, but at the same time ensure that the needs which are arising from the impact of COVID are included in humanitarian response. However, caution needs to be done while including or excluding activities during the revision exercise. So the revision involves three important aspects: reprioritizing of activities. I'll talk more in detail about it. Adapting existing activities to operate under new operational constraints. And then also aligning with the HRP with the country COVID-related preparedness and response plan. So reprioritizing, adapting, and aligning. So I'll talk more in the next slide about reprioritization, how it is done, and so on. So what do we mean by reprioritization in this case is the activities we already have as part of the HRP may need to be scaled up because there are additional needs which are arising from COVID, or may be scaled down because there is more priority on a certain activities, and the activity which used to be a priority, which may no longer be a priority. So there is, in terms of ranking of priority, there may be a change in our list of priorities as a result of the impact of COVID. Another reason for reprioritization may be the operational context itself. Some activities with the current operational context may not be feasible and cannot be implemented. So those activities need to be excluded considering the operational challenge you may be facing. Adapting is more or less related to the point I just mentioned. Some activities, the mode of delivery, how we deliver it is because of the COVID, it will have to change, and it will have to be adjusted to our operational modality, which was affected by the COVID situation. And aligning, as I said, the COVID specific preparedness and response plan, these are more country government-led plans. They may not necessarily have a component of HRP, or HRP may not have included the activities those which are included in the COVID preparedness and response plan. So what we need to do is activities which are included in the national level COVID preparedness and response plan should be integrated to the HRP revision. In terms of approach, countries have two options to do the revision. One option is, as usually it is done, in the HRP document, there are a general section where the general explanation of the needs is indicated, the financial requirement, the aggregate of everything is indicated, and then another country sector-specific page. So it's up to the country to choose how to reflect the revision in the revised version of the HRP document. The second option is the countries may choose to put just COVID-specific addendum to the HRP. So no need to integrate into the different sections of the original HRP document. Instead, just an addendum of a number of pages specifying what revision has been made in the HRP. Next. Yeah. So as I said, I think it's very important for colleagues really to pay attention to this one. In the HRP revision, we really need to keep in mind these important points. Of course, we know that it is context specific. Each country, OCHA, or whoever is coordinating the revision exercise, we hope they will share some kind of guidance, country-specific guidance, but it is also important to take into consideration some of these general guidances. Now, as I said, there is an element of prioritization of existing activities. What it means is that existing activities you have in your HRP may be changed, may be scaled down, or may be paused for the remainder of the year. So this depends on the need, whether or not the need is relevant, or the need is going to continue to exist, or the need is really less priority because new needs have emerged as a result of COVID. So that need to be looked at by each sector, by each country revising the HRP. What is really important for us, for country colleagues, is you need to reflect on how the COVID might affect the implementation of these activities. So one aspect of prioritization is checking whether the activities which are included in the original HRP are doable in the current operating environment. As we all know, in most of the countries, the operating environment has changed. The movement of commodities, staffing, because of social distancing, infection prevention measures, and all of that, our mode of operation has significantly changed. So we need to ask ourselves whether or not the activities included in the HRP are still doable in the changing operating environment. And also, you need to ask whether or not the current activities you have in the HRP are supportive of the COVID response. Some activities, I think a typical example would be a wash cluster activity, which is like hand washing, hygiene. Promotion is a typical wash activity, but when it comes to COVID, it becomes much more important and much more impactful. So this is a kind of activity that need to be really widely scaled up. So we may have similar activities for nutrition. Maybe David will talk about it. What would be the nutritional consideration when it comes to continuity of existing activities? But keep in mind that there is a need to look at existing activities and check whether those activities are supportive of the COVID response or not. Another important aspect which we need to consider is, in terms of including new activities, we should all focus on directly targeting COVID-19 needs. So new activities are, in most cases, are likely to be included because COVID has affected and is going to affect far larger number of countries. In fact, we don't know much now about Africa. Over the coming months, the situation may deteriorate. Maybe countries in the MENA region or in the Southeast Asia region. So as we continue throughout in the remaining months of the year, we need to think about what kind of activities can possibly address COVID-related needs. So these ones, just to be clear with you, that we haven't really come up with a concrete list of activities. I think country clusters and their partners need to be really creative, because this pandemic is the new kind of situation, and the only thing we could do, of course, we do have issued a number of guidances on nutrition emergency and coordination, but those ones may not answer all the questions. So we would also anticipate countries to be more creative on identifying activities, nutrition-specific activities that will directly target COVID-19 related needs. Also, you may have activities not included in the HRP, but because of because back then there is no COVID situation, then now it becomes necessary that these activities automatically need to be included. So this is, I think, is very straightforward. So in terms of including new activities, I think it's very important to consider these two aspects. The other important aspect is scaling up of the COVID relevant activities. Some activities, as I said, if you look at the JHRP objective priority strategy objective 2, one important focus of that is addressing increasing needs of already vulnerable people included in the HRPs. So there may be additional needs arising from the COVID. So in that case, I think it is necessary for the country cluster sectors and the nutrition working groups to ensure that existing activities are continued to be scaled up. So these are important considerations we need to take in the revision exercise. These are very general. We will also be available even to give more clarity. But in general, at least looking at this as the minimum would be helpful as we continue to understand the process more. Next slide. So all this reprioritization, scaling up, scaling down require data. But as we indicated in our coordination guidance in the context of COVID, assessments are definitely going to be difficult to conduct, because we have to rely on remote mechanisms of collecting data and conducting assessments. So it is not as anticipated that there will be more assessments done in this COVID context. So if new assessments are available, make use of those available data. But as much as possible, as indicated in the global HRP review guidance document, most of the revision has to be based on secondary data from in-country, and it has to be done more on a desk review basis. And countries should also try to learn from other countries. Some countries with at the moment, I don't think that we have really examples from countries, but maybe we'll see over the coming months countries which are affected by COVID and which have at the same time humanitarian needs. They may have a certain systematic way of coming up with needs. So it's good to learn how they came up with the need analysis of COVID-related nutrition or other sector needs. So mostly the data source should be secondary source. It should be based on on the desk review. And in terms of the revision of on the needs analysis, there is no need for doing a full-scale HNO revision. That is not required at this stage. And we have to simply focus on limited number of indicators, which are already included in the HNO HRP right at the beginning of the 2020 HRP. HNO exercise. These are needs and target indicators. We look at those need and target indicators and then see whether there is a likelihood of increase or decrease in the needs which are identified by those specific indicators. So those are, we are not expected really to come up with a new indicator and then do look at our data set and identify, the needs based on a detailed need analysis, etc. That's not really required. We look at what we have identified as a need and then see whether those needs have changed because of COVID or not. And then accordingly, then we proceed to how much of that need to be targeted in the revised HRP. And among those the activities, which ones can be implemented in the context of COVID. So in general, these are the considerations I think we need to take. I know that this is really too general, I have to admit, but we are available to provide more one-on-one support. We will open for question once David finishes the more nutrition-specific slides. So I will hand it over to David. David, over to you.
Yes. Anthony, will you talk about the PIN or not?
I think it would be good if we come during the Q&A part.
Okay.
I'm sure the colleagues will raise about the Q&A, the PIN, and then we will have time to discuss that. If the question is raised, fine. If not, then I will come back to that.
Yeah, no problem. I will go into the nutrition specific. So good morning, everybody. For those who don't know me, I'm David Rizzi, the coordination help desk at the GNC. So I'll present a bit the nutrition specific consideration for this HRP review, following up on the path that Antena has showed us. So first of all, it's important that we, you as a nutrition cluster coordinator, discuss within the nutrition cluster and identify with them which are the nutrition intervention now to reprioritize, stop, add, adapt, as Antena said. So indeed, there are some activities that may have to be put on hold because they are no more a priority at this time, or because they are unnecessarily exposing beneficiaries and staff to risk of transmission of the COVID. An example for all is surveys or mass MOAC screenings. So if you had budgeted, for example, a national survey in your HRP, it's better to postpone now so you can review this into the HRP in the new HRP. Diagnostic of malnutrition, of course, remain a life-saving activity and should be continued, but the modality have to be adapted. For example, using protective PPE, personal protective equipment, mother MUAC, avoid gathering, etc. But we have a dedicated NIS brief prepared by Victoria and the GTAM group. So have a look at that one because you will find more specific technical information on this point. As Antena said, so we can also consider adding new action if needed to the HRP, but honestly, we couldn't really identify anything, completely new, specific, action to recommend, and that can be applied throughout, the countries that we operate in. Maybe I see communication for development campaigns in this case on hygiene practices, distancing, to prevent transmission, or the importance of breastfeeding continuation. These are recommended, but we suppose these are somehow already in place in your countries. If not, you can add again to the new HRP, or they can be scaled up, expanded, etc. What for sure will be needed is an adaptation or update of old nutrition in emergency programs to the new context. And we've mentioned new ways of screening, for example, but unless that there's a significant cost implication, doesn't need to be included in the HRP update. Now, the big question we receive as help desk is: shall we expect an increase in the overall number of SAM and MAM cases? If so, by how much? I'll give more details on this point in a minute, but basically nobody knows yet. And even at country level, if we stick to country level, it's very difficult to make a prediction at this point. So at global level, it's even more complicated for us giving you guidance. Our recommendation is that you consider your baseline nutrition situation, the likely impact of COVID in your country, considering the context, etc. And as they say, it's better to be safe than sorry. So if any, err on the side of caution. So by increasing the number of potential undernutrition cases. But I'd like to make here a clarification on the direct and the indirect effects of COVID. Because when we talk about direct effects on health, those are usually mild in children who are our main target for malnutrition, at least so far, based on the experience mostly in affluent countries. And the population of the countries we work in is very young. But so on this side, we don't expect a worsening of the situation. But on the other side, please bear in mind that some children, being immunocompromised, may be at higher risk of complication. And this has been also acknowledged by the WHO in official communication. So make sure that malnourished children and people in general are always included in at-risk groups for COVID complication. And whenever there is any action, activity, program designed by relief agencies or government to address the needs of at-risk groups, please make sure those people, malnourished children, are included. But so more than these direct effects of COVID on the health of malnourished children, we have to, I think, we have to be worried about the indirect consequences, and this may have a significant and long-term impact on on the entire country system. So it's difficult, of course, to make predictions, especially at global level across all your countries. But please consider that there are many variables that may increase the vulnerability to the epidemic, and so eventually the impact of the epidemic on the nutrition status of the population. I will just name a few, but this is part of the exercise for you and your nutrition cluster members to think about these variables and their likely impact in your countries. So think about, for example, the density of population. We have very high density, high densely populated refugee camps in the Middle East and elsewhere. The socioeconomical status of the population. Of course, the poorer the people, the less coping strategies they will have. The social services availability. For example, what happens if a child loses parents because of COVID? Will there be a system, taking care of the child? The healthcare system, the quality and the coverage, how good is that to respond to the health emergency? The age distribution, as I said, children in general are less likely to have complication, etc. But in our cases, this can be, in cases of malnourished children, this can be a complicating factor. The containment measures imposed by the government, this can also have a huge impact on people and systems. Sometimes they can be even worse than the COVID itself. Wash services, for example, how many people share one toilet. The population mobility, the more the mobility, the more likely is the virus to spread, rapidly and throughout the country. Budgetary constraints, the economic and financial stability. I mean, I will stop here because there are endless possible of consideration to take into account. And moreover, these factors may and of course will change rapidly. So be quick in identifying the trends and take action as quickly as possible. Now, we are available to support you in this exercise, but it's up to you to launch it, to do this sort of scenario building exercise by assessing the country specific situation and come up with an outlook for this HRP review. Now let's go back to the sum and numbers. What we should expect. So on the short term, if on one side, as we said, many experts, many expect COVID to create the condition for a spike in admission to CMAM programs because of its indirect consequences on food security, WASH, comorbidities, etc. On the other side, and we've seen this happening with Ebola, admissions actually might go down, and not because there is less malnutrition, but because people will be afraid of visiting facilities because this will be overwhelmed, because movement restriction, healthcare staff will die of COVID, chain supply will break. So these lost opportunities of providing essential services may actually be deadlier than the virus itself. And so it's very important for us, for you, to bear this in mind when advocacy opportunities arise. Please also consider implementing simplified protocols or blanket interventions if appropriate and feasible with regard to available resources and the government regulation. But they are, of course, one of the tools available to us. One change likely to happen in our view and that we have to get ready for is a possible increase in the proportion of some children with complication. We usually estimate at 10% the proportion of some cases of complication. In this case, we might go beyond that number, that proportion. And this will happen at a time when hospital will be under high pressure. So you may want to account for more bed capacity, human resources, supplies, etc. And, this may find its place in the HRP review if you estimate, the budget change, for example, is significant. With regard to IYCF, well, we are not getting into the technical stuff here. A technical note, again, by GTAM has been circulated on IYCF-E and COVID. So please consult that. And we have also another one on wasting and see, what's relevant and applicable, to your country. But what we need to consider here for the HRP review is that the conditions are there or will be there for mother to be more stressed and with less access to IYCF and healthcare services. And they will possibly be afraid of contagions through breastfeeding if we are not careful in the way we design our messages. Now, whether this needs special actions or just expansion, this depends on your context. So it might be included in the HRP or not. If it's just a small scale up of activity or adaptation, it doesn't need to be singled out. But if you didn't have, let's say, an IYCF specific action and now you think it's relevant, please consider adding it. So I hope this helps a bit. I mean, please understand us. We, like you, we have more questions than answers at this moment. There's a lot of uncertainty on how this virus and the containment measure will lead our beneficiaries, and things are, changing rapidly. But me and Antenne, we had a webinar on preparedness in the occasion of the launch of the GNC preparedness guidance. And if you were there, and if you remember, the first point in preparedness process is risk monitoring. So in this case, the risk we have to monitor is the COVID expansion in your country. So the first, recommendation is, to make sure that you stay updated on the pandemic evolution in your country, follow the number, attend the health cluster, possibly be updated on the government measure to contain the epidemic, so that you can quickly adapt the nutrition programs and respond to this risk. Well, among the recommendations, as I said, no one size fits all. For action in this case, a lot of adaptation, specific application of the measure will be needed. Consider it's a very, multivariate situation with a lot of uncertainty, so be flexible but quick at the same time. Sorry. And as I said, because it's changing rapidly, you have to think in terms of short, medium, and long terms consequences and actions. For example, the direct consequence on the children might be on the very short term, but on the long term, we see a lot of possible indirect consequences. So I'll close here my presentation. We can move to the Q&A session, unless Victoria had something to add on on my bits.
David, may I come in, Stefano? I need to rush off to another call. Just 1 second.
Sure.
Okay, just wanted to say thank you very much for the excellent presentation. Very well done. And also I really appreciated the clarification about these direct support and direct initiatives in response to COVID. Unfortunately, I'm sure our colleagues in the field are going to have some difficulties, because at the moment the focus is very much on the infection prevention and control, the IPC. So a lot of the initiatives discussed and prioritization at the country level are going to be directed to prevention of transmission of COVID. And while that it's absolutely right to do so, we also want to make sure that the risk for children with malnutrition, especially with severe wasting, are not forgotten when the resources are redirected towards infection prevention or control. And I was about to share a couple of links with there are some useful guidance and advocacy material on our website. And in particular, I think that it may be useful to many of you to have the COVID and wasting advocacy joint statement from UNICEF and GNC. And I stress that even though we, as David said, we do not have a crystal ball, we don't know what's going to happen in the future. I think that globally we do expect an increase in deterioration of the nutritional status, in particular in countries which had a pre-existing nutrition crisis. So it's very much likely that the nutritional status will get worse of children and adults. Food security is likely to increase. Livelihoods are increasingly put under stress, and the economic crisis, as you well know, is already affecting global markets. So the outcome for the next few weeks and few months is not positive, and we need to try to ensure that we prepare as best as we can. And that's all from me. Thank you very much, and bye.
Thank you, Stefano. Thank you for the clarification. Yes, indeed, it's quite a scaring perspective, and will be available for supporting, individual countries on how to estimate this situation in the future. Victoria, did you have any point?
No more points to add, and just conscious of time, perhaps what I've seen so far in the chat is some colleagues have been sharing some experiences from Zimbabwe, from Bangladesh. There was a request for the reference for you, David, in terms of the 10%, more than 10% increase in cases of SAM with complications. But perhaps we can open it up to the floor and maybe using the raise hand or even just jumping in for any questions that would be relevant for all colleagues here, or we could be following up individually as well with the numerous emails and contacts that we provided on the last slide.
Can I clarify just one point, because maybe there's a bit of misunderstanding on the 10%. So when I said 10%, that is the commonly known proportion of some children with complication, right? So this might increase because of the COVID, because children with severe acute malnutrition might have higher risk of complications. So I'm not saying that the proportion of children will increase of 10%, right? I'm saying that the 10% is usually the norm or the average, and we expect this, it might increase to, we don't know what, 15, 20%. Over, Antene, over to you.
Yeah, great. Thank you for that clarification. Antene?
Yeah, I think colleagues, if you have question, please, you could raise your hands or you could just go straight to the question. If not, I really want to go back to the pin slide, which I intentionally left it there because it is more general. It doesn't really respond to, I'm sure some of you were asking us on one-on-one basis, how specifically we can estimate the nutrition pin, which is arising from the impact of COVID, which in short, we do not have answer at this stage. So, but in any case, I can go back to the pin overall calculation, the general OCHA pin calculation in case of COVID. If you do not have any question, if you have question, let me see your hands, or you could also use your mic and you could raise a question. Yeah. Who is speaking?
Sorry, colleague, we can't hear you.
Who is it Koki?
May the colleague repeat the question? We couldn't hear you.
Okay. I think we cannot hear. So I would go straight to the pin slide, and if anyone has a question, we could address the question afterward. So in terms of pin calculation, in general for the intercluster calculation is very straightforward. The existing PIN, which is the PIN, the people in need of humanitarian assistance, estimated during the HPC exercise early in 2020. If it hasn't changed, it will be kept as it is, plus the health PIN, which in this case is COVID direct health PIN, and plus additional expected people who would become acutely vulnerable or or acutely in need because of COVID. So these are the new needs arising from COVID. So in general, it's very straightforward. But now, as I said, the main question is, how do we specifically estimate the needs arising as a result of the impact of COVID on nutrition? That's a bit difficult. We do not have a baseline for that. Even estimation needs some basis. And I think we leave it to countries to really build their own scenarios. And also OCHA might give, or whoever is coordinating the country level HRP revision, they may give you an idea how many people in general will be affected by COVID indirectly, not the health impact, but indirect impact that may lead to increase in need of humanitarian assistance. So you use that, and then you look at also how much of that would be nutrition need. Like we usually use, for example, in IDP context or returnees or refugees. If, say, for example, if we have 100,000 of IDPs, it is more likely that close to 25% of those are likely to be children and pregnant and lactating women. And those are considered vulnerable to nutrition. And then we look at also pre-existing nutrition situation in that area, in that population, and then we can estimate the specific nutrition needs for the different nutrition and emergency needs. This is a general approach. I'm not really very confident how this can be utilized in case of COVID. So, as I said, this aspect of the PIN, the nutrition PIN, we do not have a definite answer, but we encourage you to stick to your contextual estimation of general affected population, and then based on that, you can estimate also the nutritionally in need among those COVID affected population. Over.
Any other burning questions? We're aware that we're now over time. For the health PIN, this would be led by the health cluster colleagues and the sectoral colleagues. So in terms of nutrition, we don't have the specific details on how they will be estimating PIN, but once again, they would probably use the same indicators that they have for the existing health PIN and then be adapting those estimations. That was one question that came through the chat. Norbert, you unmuted yourself? Did you have a question? No? Okay. Nothing else is coming through the chat, Anthony. Maybe we just wrap up?
Yeah, I think we need to wrap up. David, maybe if you could wrap up and also clarify how countries can receive support from us.
Yes, thank you. So as usual, as we have done for the standard HRP, myself and Yara and Victoria and Tanka will be available for directly, supporting you in drafting, reviewing the HRP. So don't hesitate to contact us. I mean, we'll have quite a number, I think, of countries requesting for our support. So the sooner you do it, the better, because we might not be very quickly in responding. For any other things, well, you can call us, email us, and we do our best to help you in this exercise. And yeah, that's it for me. Antene, shall we close it?
Yeah. So, yeah, thank you. Yeah.
Good.
All right, colleagues, thank you so much. As David said, get in touch with us and you can have our remote support as usual. Thank you. Bye-bye.
Bye-bye. Thank you for attending.